Okay. Okay, so we're talking about sending specimens for culture. And I know we talk about swabs a lot, and we'll get into some specifics there, but I mean, I'd rather not have to talk about swabs at all. I mean, we should be sending higher quality specimens. So that would be, you know, a visible size chunk of tissue, or if there's an abscess, drain the fluid and don't throw it away, send it to us for culture, because that's really, really good specimen. Rather than like maybe a swab dipped into the abscess fluid, if you have, you know, a good amount. You can just go ahead and aspirate it, cap off the syringe. That's totally fine to send this kind of specimen to the lab, or you can drain it into a sterile container. Scrapings is more for the outpatient setting, so I'm not going to talk too much about that for the OR. So anyway, this is my point. Is I see so many cases, because I do consult for search paths sometimes on infectious cases, where they have this beautiful chunk of tissue and it's all fixed in formalin and it shows fungal organisms or bacteria, whereas for the microlab we didn't get that beautiful chunk of tissue. We have maybe a swab or a tiny little bit, and it doesn't have that same quality and doesn't have the organisms on it because it was a very small sampling. And so that does frustrate me. I don't know how we can maybe split off a little bit of those tissues sometimes, especially if you have like pus or mucus or some area that looks infectious and you're not worried about tumor margins or anything like that. Try to get a little bit of that for culture rather than a swab. That's kind of my plea to you guys, if you can help us out for the patient. I don't know if there's any comments about that and things I'm not aware of. Please let me know. Any questions about collecting tissues or fluids? Now's the time to ask. Well, anyway, while you guys think about that, you know, sometimes we get questioned, well, how do you submit it? It's really simple. Like if you want culture and you have tissue, just send that to us. Just don't put formalin in it. If it's large enough and you don't worry about it drying out, just stick it in a sterile container. We get chunks of bone sometimes like that, no problem. If it's smaller, like, you know, barely visible or just like, you know, a couple millimeters across and you don't want us to lose sight of it, you can definitely put it in a little bit of saline on a piece of soap, you know, moist gauze and keep that from drying out. And we'll show you the e-swab tube. This is actually really nice liquid media that preserves bacteria really well. So you can stick little pieces of tissue just in the media. Don't use the swab, just discard the swab and stick it in that tube and screw the cap back on. And we'll see the tissue and we can process that whole thing, which is going to be infinitely better than just a swab of that specimen, because we're going to have so much more material to work with and recover any organisms. Let me get this to the presentation view. Okay, so that's kind of the first thing. We'd rather just not see swabs. That should be a minority of specimens for culture. I'm sorry, I'm getting really bad feedback. Okay, I think that's better. Thank you. Okay, so if you have to submit a swab, we shouldn't associate cultures with swabs. It should just be a swab as a kind of thing of last resort. And I would say, yeah, if it's hard, it's like you got a meatus and it's hard to get in, and you just need to get in and get the specimen out of a very difficult to reach place. A swab's a great specimen. The e-swab is pretty good. Like if you just need to do really superficial kind of, you can't get tissue, then you can scrape it pretty nicely with the tip of the swab here. So this should be kind of a last resort for specimen collection and culture. So the e-swab refers to this kind of system. It says e-swab on it, so you can easily identify it. And then also it's about 1 ml of liquid. It's not gel, it's just liquid amines transport media, a very nice buffer. And the swab tip is going to be fuzzy like that. It's got a lot of bristles on it. And it's just a very nice system compared to the old Culturette swabs, which we have now, unfortunately, because of supply chain issues. So this is the one that we've had to use because of COVID. Because of COVID, we had a huge supply shortage of these swabs and these transport media for various reasons. So these come in and out of stock. I understand a big shipment came this week, so I'm hopeful that we can get these to you guys to use. They come in all sorts of colors, by the way. So this is the regular tip, kind of a fatter tip. Comes in a white cap tube. The blue and the green are fine too. It's just that the swabs are a little bit smaller. But I don't care. As long as we have one of these, it's fine. So this is the old-fashioned gel swab. It's basically just a woven tip swab and a gel, kind of the semi-solid gel material at the bottom. And this is old-fashioned, not considered as good. You can imagine when you get the goo on the tip and you stick it in the gel, then it's just, you know, then whatever specimen's here gets into the gel too, and it's hard for us to retrieve everything out of it. But the gel's there to keep moisture on the swab. We have had a lot of cases where a small piece of tissue is evident on the gel swab, but it's been jammed into this tube, and these are long and skinny, and it's really hard to retrieve everything that gets jammed into the gel. And we do our best to retrieve tissues from that and then count it more like a tissue culture rather than just a wound swab culture. But like I said, if you have tissue, please don't jam it down there. Just put it in a sterile container, or if it's really small, you can just plop it into a liquid transport of the eSwab system. And if you discard the swab, we'll know to look for tissue in here, so we don't get confused thinking we've got to process that swab tip by, you know, vigorously vortexing and forgetting to look for any tissue. Okay, and then this is just to show you, we did a bunch of experiments many years ago. It's comparing that gel swab recovery to an eSwab recovery. We had a lot of different organisms we played around with. This is just to show you the old-fashioned swab. If you dip it into suspension of Staph aureus and then plate it, and you know, this is a pretty high dilution, and we're only recovering a few, whereas both mini tip and regular tip eSwabs, we're going to get a lot better recovery with the eSwab system. So that's kind of why I'd rather you guys be using eSwabs if you have to use a swab at all, rather than the gel swab. Okay. And then this is my last info, AFB cultures. This has been, I know there's a lot of back and forth, you know, what do we need to send for AFB cultures? Out of the 4 cultures we do, aerobic, anaerobic, fungal, AFB. AFB is the one we have to send out, and ARUP Laboratories is our reference laboratory. So this is from their website, their specimen requirement. So I know I emailed some of you this, but just thought I'd share with the group. This is their specimen requirement at that lab. And from OR specimens, you know, body fluids here, they really like to have as much as possible to recover AFB, minimum 1 ml of just that body fluid. For tissues, any minimum visible amount is considered good. Whereas they're saying unacceptable conditions includes dry material or material collected and transported on a swab. So this is why, you know, we get a lot of phone calls from ARUP pretty much admonishing us for daring to send swabs all the time on specimens when it's really unacceptable, and we have to tell them, well, it's from the OR, please process. They'll accept it, but we constantly field phone calls from them trying to reject these specimens. And, you know, this wasn't a problem before when we used Quest laboratories. They weren't very strict about it, but ARUP, they say they've done their research studies and evaluations, and swabs just don't recover the AFB very well. The AFB organisms are really waxy. They don't like water or liquid. So if you're taking a specimen from a swab and trying to put it into liquid media, sometimes the AFB just they don't get into the media quite as well. So that's why they rather see just a bare minimum, a visible amount of tissue than a swab. So that's just my kind of more my information here, but Pill will get into much more of the day-to-day operations and nitty-gritty. So any questions for me?
I have a question. So at a lot of times we're getting so much feedback. A lot of times we're getting the specimen from the surgeon, and they're the ones that are asking for the swab, and they're swabbing something and giving it back to us. I would say that like 90% of the cultures that we send.
Okay.
Just to let you know, so I don't know if any communication can go out to the physicians.
Okay.
I think that would help us see those more quality specimens needed for these types of tests. We can also advocate on our side, but a lot of times we're at the mercy of the physicians when they're giving us that direction.
Yeah. Yeah, great point. I just didn't know how far, you know, where the line was drawn between who decides, you know, so definitely I'd be more than happy to send out. I mean, what do you think is the best method to get some education out on that?
Let me think about it and I'll email you. I don't know what the best venue would be. We'll definitely advocate on our side, because a lot of times it's just that like gentle nudging to our physicians, like, hey, if we send an actual, you know, piece of tissue, you get a better specimen. But it would be good for them to know as well, so we're not having that back and forth.
Yeah, definitely. Okay.
But I'll think about what would be the appropriate venue.
Thanks so much for thinking. Yeah.
Dr. Shay and Taylor, like once we have like the pictures that you shared, like, okay, if you're sending AFB, you don't need to put it on the culture tube, send a tissue. If we have it laminated, and we can just show, hey, for cultures, this is, you know, this is what lab in-service is on. And if there's any further questions, we can like give your information. Maybe that would be kind of like a first step. Okay.
That sounds great. Yeah. Yeah. And if you see them like get a piece of tissue, yeah, the e-swab would be really helpful, just to plunk it in the little liquid tube rather than a gel tube. Just, yeah. Okay. Great.
Anybody else have any questions?
I have a question. Hello?
Yes.
Yeah, we can hear you, Bria.
Yeah. If we need to send a catheter tip, can we cut the tip of the catheter, send it on a container?
You're asking about catheter tips? Do you mean intravascular or other vascular or other catheter tips?
Yeah, intravascular catheter tips.
Oh, yeah. You know, we have an institutional policy, right? So with in conjunction infection prevention, we don't, as a general rule, culture catheter tips. That requires approval of infection prevention. For example, Dr. Nanda, and if she's not around, somebody in infectious diseases attending before we perform those. But yeah, if you do have a case where you absolutely need that and you get approval, then yeah, you just cut the tip off and put it in a sterile container. That answer your question? Yeah.
Do we just send it to the lab anyway? And I guess the question is, who gets the approval from IP? Are we supposed to get the approval from IP?
Yes. I mean, we haven't set one up in years. I think last year there were a couple of exceptions where we did it kind of not reported, just under the table, because it did not meet criteria, but ID just asked us to do it anyway. I mean, the whole purpose is it's not recommended at all by IDSA, and it's just not something that our institution wants to use to diagnose like CLABSI and things like that. It's just bad sensitivity, bad specificity type of thing when we culture a cath tip for CLABSI. So as a general rule, I'm glad you bring that up. Any sort of prosthetic device or catheter device, we generally don't set those up. We really like you guys to sample from the patient biological specimen, because biofilms form on these plastic devices, metal devices, and whether or not it's significant, it just leads to kind of misleading results. So we've never, as a policy, accepted any sort of prosthetic, foreign body device.
Now, the nurse has to do it, or the doctor has to call to get approval?
Oh, I mean, it's usually an attending request, or at least an MD to, Dr. Nanda request. That's been my experience the last 2 cases.
Okay, I guess for my team, if that happens, we'll inform the surgeon, we need IP to approve the culture, and if they really want it, then we'll help you guys coordinate that conversation. But like I said, it doesn't happen very often, I think, because we also don't do a lot of those um, portacats or those types of catheters in the OR. So, but we'll develop a process within the department.
Yeah.
Then we do it for the infected one. When they are infected, the catheter, they usually send it to the lab. That's
Right.
why.
Right. Yes.
Yeah, so with those cases, I would just say just make sure you get from where the site's infected. If you have any sort of fluid or something, please sample that and send that if you're suspecting a catheter-related infection. Because the last thing we want is that they only send the cat tip and it's not approved or something, and then you don't have anything for the patient.
Right. So
But
the recommendation is if we suspect an infection, we actually want the specimen to come from the tissue, not the catheter. So we're not saying, no, you can't culture, but we want the culture to come from the tissue, not the implant or the catheter, not the device.
Yeah, and I suspect that what's being sampled sometimes on a swab is this catheter surface. I don't know what's happening, but when we get the swab, we don't really know. But if you send the catheter device, we're not gonna set it up unless there's attached tissue or obvious pus or something. Then I'll make an exception. But usually we don't accept just a a dry catheter tip.
But I believe that the doctors, they're not aware about that protocol.
I'm sorry, could you say that again?
I believe the doctors, they're not aware that they have to get the approval. The doctors, they're not aware.
For the intravascular catheter tips, always. That's always been the case. Yeah. I don't think we've set one up. Sometimes we hold it in the lab until I think if it's approved, we don't even set it up unless there's a concomitant positive blood culture. So I don't know what's going on if you feel like you're sending some and we're accepting them.
Yeah, because I
don't
have
think
two
so,
cases. I was told that
we
they
always
cannot
reject.
process. Okay, thank you.
Okay.
It's coming, but then we
we'll do education on our end, Dr. Shea, with the physicians when it happens. Because if it's so infrequent, they probably are not aware. So when it comes up, we'll do the education.
Okay, and I can find the policy number if you need that, but it's like a CP policy or something. Yeah.
Okay, that's great. Thank you.
Great.
So Phil, you still have
okay,
correct?
Yes. For the day-to-day operation that we have when the physician the CPOE happens, we usually deal with less problems. But then I don't know this group is OR or not. I'm not quite sure. But anyway, so we have a lot of problem with the handwritten requisition. So I can see that the bad handwriting is plain unreadable handwriting that we have to, to deal with. And then that was due to the cursive. They're using the cursive lettering. Oh, I can show some pictures of it later. And then too light handwriting, because we get the canary paper. So if you don't write, hard enough, then we only have a really light handwriting that is adding on the difficulty to, to read, and abbreviation too much. And that kind of makes us hard to read what it is. And all of them, affects the patient care. And the second one is the sample not enough. There's a QNS. That is a lot of times one e-swab or even one gel swab, and then there's a requisition slip there, and they check out like a 4 or 5 cultures, aerobic, anaerobic, and fungus, and AFB. And then here goes another gel swab or e-swab, and then saying the same thing. And it's like a shoulder number 1,
and the shoulder number 2, and then 1 swab. So it's almost like a 1 drop of CSF and ordering the like the 4 cultures, and just plain not enough. So since we are, even the PCR testing need a minimum amount of to go through all the extraction and all that. So just 1 swab and marking 4 tests is plain not enough. And as Dr. Shea said, the swab is not a acceptable sample for the AFB. So we we can redo the extend to the 1 swab with the AF, aerobic and anaerobic culture, because they share the 1 broth. But then we cannot send it to the fungal culture, because fungus need quite a few material, because that's a bigger microbiome, microorganism is a lot bigger than bacteria, so we need more specimens. And another case is too many swabs collected. Well, sometimes they say it's kind of BIP patients case. So I don't know. So that case, it brings us to sometimes we have 25 gel swab collected, and each one of them has a 4 the set of the culture order, and of course the AFP has to be rejected because of our limitation.
Everybody, please mute yourself. I think someone just joined 805 phone number. Please mute yourself. Thank you.
And one time, one surgeon was really upset at, she said that she collected the 6 e-swabs to send it to the AFB, but how it was ordered was a specimen 1, 2, 3, 4, 5, 6, and each swab has a 4 tests: aerobic, anaerobic, fungus, and AFB. So of course AFB and those definitely got all rejected, but the surgeon said that that's what she collected the 6 e-swab specimen, and then e-swab is not really a good specimen for the AFB. It doesn't go out to the the water, that the buffer that, well, it just sticks to that the swab, so it's so waxy, it doesn't go well with the water. And another one is a no collection time on the requisition slip or on the sample, or the different collection time between the requisition slip and a sample is another case that we see it often. And no nurse or collector's initial on the sample. So those are the most the case that we are dealing with. Let me just show you a little, let me see if I can. I have mine. Okay, so this is like a cursive handwriting, not finishing the spelling of the word, and different collection time written on the specimen and the order requisition. And yeah, we have to deal with this. Yeah, so it's very hard to read, and sample, no time on the samples, and then times are different from the requisition slip and a specimen, and then we don't know which one to go by. And yeah, those are the one kind of case that we do it. And then let me go another one. Yeah, so different collection time on the requisition and sample. Unreadable diagnosis on the section. So it says a 1630 in the sample. You know how light it is? So our level systems are really having a hard time to read, when it's not written that clearly. So it says 1640 there, but it's a 1630. then those two are different. And then we have to call the nurses and the OR, but OR is very hard to reach anybody. By the time we get a sample, the surgery is finished. So when we call, then nobody wants to, tell us anything. So that's what, so all those different time on the container, but it's not the, so those are the one we can't really, decipher what it means. That is, and let me say sample QNS case. Okay. Okay. Not enough samples, so that's how it looks like. Just one, and it just, just market everything in just one e-swab, and each case is like that. Yeah, that's how it looks like. Yeah. So in order to have, you have to have 3 swabs or 3, swabs, and then like as a number 1 and 3 swabs, and then you do that, then it's possible. But then it's 1 swab and all of it being this way, we have to reject, fungus and AFB basically. So only 1 swab is enough for one. Basically, 1 swab for 1 test is good, And then AFB, swab is not a good sample, so we have to, reject it. And even though we send it, ARAP will reject it, and we have to deal with a lot of. We have to make an excuses, and they're very reluctant. And they always give us a lecture. It's not a good space. It's gonna have a false negative. Why do you want to do that and all that? Yeah. Any questions for me?
Okay. Well, thank you very much for all the information. I will definitely, we recorded this part, so I will definitely make this available for all of our staff, and I will print out all of the examples as well. So thank you both for coming. We appreciate it.
Thank you.
Yeah, thank you guys so much. Yeah.
Have a good day.
Bye.
For all of our staff, just remember we have 2, actually 3 hallway in-services today. On Q is here, as well as I think Trish is in room 10, and she'll be going over the Jackson table. And I know I'm forgetting one more. So there's one more in-service up there at the front. So make sure you stop by and see everybody there. And then all of the newer ponies or post ponies, please make sure you check in with me today and bring your folder. Pod leads, I want to speak with you all briefly. So if you can make your way up to the coordinator office, it will just take a couple minutes for me to give you a couple of updates. Thank you, everybody, and I hope you have a good day.
Thank you.
Thank you.